So hi, my name's Dr. Neil Stoddart. I'm the lab director and embryologist at Louisville Reproductive Center. I've worked in IVF for about 20 years. I was educated originally in England, and then I came over to America in 1998 when I started my first lab director's job outside Philadelphia. My first degree was in microbiology, but I became very interested in developmental biology. So I completed a PhD in mammalian developmental biology at Southampton University in England. And then I began working in clinical IVF in 1984 at Nottingham University. It's a large centre that performed over 1,200 cycles and specialized in the treatment of severe male factor infertility with a new technique at that time called intracytoplasmic sperm injection or single sperm microinjection. My role as embryologist is really to work with a team of physicians, nurses, andrologists, reception support staff, medical technologists. Primarily, as an embryologist, I'm involved from the moment that we do the collection of the oocytes and also begin preparing the sperm in order to produce embryos. We do that essentially by collecting the eggs surgically in an operating room. The embryologist has to identify the eggs and wash them and keep them in an appropriate culture environment to maintain the viability of the eggs whilst we're preparing them to be fertilized. The two major ways of achieving fertilization, the old-fashioned way is with conventional IVF, in which we take the eggs and surround them with a number of purified swimming sperm in a small drop, and we leave the eggs and the sperm to interact overnight, hopefully achieving fertilization. There's a more direct way which we use called intracytoplasmic sperm injection. It's been around since really the early 1990s. It's become very mainstream now. That involves injecting single sperm into the eggs using a very fine glass needle. It's about 1/14 the thickness of a human hair. And it requires a special set of equipment, an inverted microscope and micromanipulation equipment that allows the movement of the injection needle to be stepped down to a very small movement. So if I move this joystick, it'll move the injection needle and allow us to have very good control over injecting the sperm into the eggs. So the ICSI techniques usually used where the sperm number is very poor, where the sperm are not swimming forward very well, or where the quality of the sperm is low. So conventional IVF's really for patients where there's no what's called male factor infertility, where the sperm is fairly fertile and the reason for the couple's infertility is some other reason. So after we've united the eggs and the sperm to produce fertilization, we then culture the fertilized eggs normally for 5 or 6 days in an incubator. It's very demanding in terms of the environment that the fertilized egg and the embryo require to maintain their potential to implant and form a pregnancy, because the embryos are very sensitive to the environment. So that's why we do that in a very controlled environment that's pressurized. The quality of the air is very high, it's very clean, and we have to maintain very tightly the pH and temperature, which we do in incubators. And then at the end of that 5-day process, normally what we do as embryologists is try to select the best 1 or 2 embryos and transfer them back into the uterus, into the womb, in the hopes of achieving a pregnancy. Sometimes there are embryos left over after that process. And if they're of sufficiently good quality, we freeze them and store them. We freeze them with a process, a relatively new process called vitrification, which is very effective at preserving the pregnancy potential of the embryos during frozen storage. And if the couple don't achieve a pregnancy with the initial transfer, we can thaw them out and transfer the frozen embryos, usually again 1 or 2 at a time. So that pretty much gives you an overview of my job as the embryologist. It requires a lot of attention to detail at every step in order to maximize the success rates in the center. And I think also, for me, on a personal note, it's a very satisfying job to do when a good proportion of the couples that we treat are successful in achieving a pregnancy and having a child of their own, which is what this business is all about, really. So it's a great honor to be involved in treating patients that are having problems having children, and I've enjoyed doing that for 20 years or so. Technology always changes, but fundamentally the most important thing to me is treating the couples in a way that maximizes their chances of success in a very individualized way. And that's really my approach to being the laboratory director and managing the lab here. Thank you.